Hello, my name is Nora Super, and I'm the Senior Director of the Milken Institute Center for the Future of Aging. Welcome to our session on healthy longevity, new strategies for a new normal. Today, we'll be discussing the opportunities to transform the way we age to ensure better health, function, and productivity during longer lifespans. The human lifespan has increased dramatically since the turn of the 20th century due to breakthroughs in medicine, public health, and social and economic development. The current decade was to be one of progress on healthy longevity, with major international initiatives paving the way. The National Academy of Medicine has launched the Global Grand Challenge on Healthy Longevity, and the World Health Organization declared 2020 through 2030 the decade of healthy aging, as an opportunity to bring together governments, civil society, international agencies, professionals, academia, the media, in the private sector for 10 years of, quote, concerted, catalytic, and collaborative action to improve the lives of older people, their families, and the communities in which they live. Yet since March, 218,000 Americans have died in the pandemic, and nearly 80% are age 65 and over. Globally, there have been nearly 40 million confirmed cases of COVID-19, including more than 1.1 million deaths, according to the World Health Organization, a large percentage of whom are over age 65. The COVID crisis has dramatically elevated awareness of threats to the health of an aging population, not just infectious diseases, but age-related chronic conditions that inhibit opportunities to expand the healthy human lifespan. The pandemic calls for new strategies to prevent setbacks in advancing the physical, mental, and social well-being of older adults. We've brought together a wonderful group of experts to discuss how can we continue to advance these efforts, drive innovation, shift policy, and lead to a future of healthy longevity. Joining us today, we have Dr. Freddy Abnousi, the head of health technology at Facebook and a practicing interventional cardiologist. He also serves as innovation advisor to the American College of Cardiology, professor adjunct at Stanford University School of Medicine, and assistant professor adjunct at Yale University School of Medicine. Next, we have Richard Ashworth, who is recently named president and CEO of Tivity Health. A pharmacist by trade, Mr. Ashworth has a keen understanding of the many factors that influence health, including social determinants, adherence to treatment, and a healthy lifestyle. Richard Ashworth joined Tivity Health as president and CEO in June 2020. Previously, he facilitated the growth of Walgreens for nearly 30 years, transforming the company into a global leader in pharmacy and health and wellness. Anna Dixon is the chief executive of the Center for Aging Better, an independent charity located in the UK that brings about lasting changes in society so more people can enjoy later life. As part of the What Works network, Aging Better is focused on bringing about impact informed by evidence across 4 priorities: fulfilling work, healthy aging, safe and accessible housing, and connected communities. And finally, last but certainly not least, Dr. Frida Lewis Hall, former executive president and chief medical officer of Pfizer Incorporated. Dr. Lewis Hall has held leadership roles in academia, medical research, frontline patient care, and at global biopharmaceutical companies. In 2010, Dr. Lewis Hall was appointed by the Obama administration to the inaugural board of governors for the Patient-Centered Outcomes Research Institute. She is a psychiatrist by training and a longtime friend of the Milken Institute and our Center for the Future of Aging. Good morning, everyone, and thank you for joining us. I'd like each of you to ask you each the same question to get us started. I'll go to you first, Freddie. Before the start of the pandemic, what areas were the most promising for improving health across the lifespan? And have those areas changed over the past year?
Thanks so much for the question, and pleasure to be with you all. Well, so the areas that originally led to improvements or changes in health outcomes in America, for the most part, remain the same. and in fact, I would argue have been accentuated in their importance because of what's occurred over the last year. So particularly, if you look at the health outcomes of folks who have dealt with COVID over the last year, you'll see a significant inequity in outcomes across the country, fairly similar to the spread of outcomes that existed before we started. So if you look at health outcomes from California to Mississippi, from coast to coast, you end up seeing a 20-year discrepancy in life expectancy that existed before. And that inequity in outcome tends to be mimicked under the stress of COVID-19. And the question becomes why? And we know prior to COVID-19, the reasons behind the major drivers of health outcomes in America were really broken down into four major categories, those categories being exposures to bad things, genetics, access to quality health care, and social and behavioral variables, these social determinants of health, which we'll hear about today as well. And we knew the major driver of health outcomes, the lion's share, the 55%, more than half of the drivers of outcomes in America were originally designated to social and behavioral variables. I don't suspect that's changed, and the reason why I don't think it's changed is because the results we've seen before, which is this inequity in outcomes across America being profoundly shown as a 20-year discrepancy in life expectancy, continues to be emphasized by the folks who are doing the worst from this pandemic. Those who are most vulnerable tend to do really poorly with these types of things, these stressors to the system. As unprecedented as this has been the catalyst for us to see this in greater detail, which is absolutely unfortunate at the using the best terms I can without sort of getting too emotional about this. So I'd say the reasons haven't changed. COVID has continued to accentuate the shortcomings of our system, the shortcomings of understanding and impacting the social and behavioral variables that drive health outcomes. And I think we're in a position to hopefully do more about it now than we were before. I'll stop there.
Great, thank you. Richard, how have things, what did you see that was promising in the beginning, and how has that changed in the past year?
Yeah, thanks for the question. I think, our view is that the majority of what we're seeing is not so much a change, but is really an acceleration of what we already knew or were already planning for. Before COVID, Tivity is really focused on social engagement, fitness, and nutrition for seniors in the health and wellness space. It's why I pivoted from Walgreens, which was treatment and care, and everyone I saw had already been diagnosed, to trying to get farther up, in terms of people's lives, to help them prepare for, well, not something like COVID. Nobody can prepare for that necessarily, but for, healthy living and healthy aging. What we were focused on before was getting as many seniors physically active as possible. And that's our bread and butter. We do that through our Silver Sneakers program. Great. And we're getting people to go to the gym. We're getting people to work out in their communities. We're getting people to just be more active. COVID disrupted that like we've never seen before. Most of the participating locations in our gyms were closed. And if you look at what seniors are saying now about physical activity, it's just an acceleration of saying, hey, before I used to go to the gym and I used to work out at home. Tomorrow, I actually still want to go back to the gym, but I want to do more in my community as well. So that was a big change that COVID brought. If you look at digital, only 30% of seniors were involved in any type of digital work as it relates to fitness. Now we're at 52%. And if you look at those that are going to continue to use digital, we're at 80% are wanting to stay with some combination of physical and digital. So to me, digital's been probably the largest changer to all of that. In terms of social, before COVID, 4% of our seniors said very often they felt isolated, they felt alone. Now during COVID, we're at 20%. So the impact of the social determinants of health, right, all those factors that impact where you work and where you live, COVID is accelerating the discomfort and challenge around those in a way that we've really never seen before. And I also think on nutrition is another one, because before people had routines and the things that they were doing. 7.3% of all seniors are food insecure before COVID. That's 5.5 million seniors had some type of insecurity around food prior to COVID landing. And all of the stats now are progressively worse. And so we were focused on those three things before COVID. We're focused on those three things after, but we're going to make digital a really integral part of that, because it's clear that this community of individuals is willing to engage in it.
Great, thank you. Anna, you're located in the UK, so you may have a sort of different experience than our US speakers. Can you answer this question from your perspective, and what you had been looking at prior to the pandemic as areas that were most promising, and then how those areas may have changed over the past year?
Well, the picture is very similar to what we've just heard about in the US. So we were seeing gains in life expectancy, but that had slowed, particularly for the poorest in our society. And whilst on average we were living longer, we were not living longer in good health. And there are huge inequalities, particularly socioeconomic inequalities, which meant that between the poorest groups and the richest, there was about an 18-year gap in healthy life expectancy. And, you know, I think, as everybody said, that was an issue before COVID. And what COVID has done is just shone a spotlight on those health inequalities, and, you know, sadly, with devastating consequences. So here in the UK, poorer people were twice as likely to die from COVID as people from who were in richer circumstances. And I know that here as well, we've been looking at the racial disparities, and I know there's some sort of similar statistics in the US showing the much higher rates of death from COVID amongst Black and minority ethnic populations. We know the causes of those, and at the Centre for Aging Better, as you mentioned, we work both on the issues of behavioural issues like physical activity. So we knew before COVID that about more than half of 65s were not doing the recommended physical activity. And we've seen a real split, with some people exercising more and some becoming more sedentary because they're now not going out to work and finding it more difficult to access facilities to get out and about. So there's a real need to redouble our efforts to promote physical activity, and we're focusing there on things like active travel, walking and cycling. The second thing, though, we know is that these wider determinants also affect those health inequalities. And before COVID, we were really focused on helping people to stay in good work, to live in a safe and accessible home, and to find connections with other people in their community. And I think, as others have said, you know, COVID is impacting these, not all negatively, but it's certainly, we still see the need to work on them. And, you know, whether that's helping people get back into work if they've been made redundant as a result of the economic downturn, whether it's about recognizing the huge negative impact of living in a cold and not well adapted home, especially we're spending so much more time as a result of COVID in our homes, redoubling the efforts to make sure that all new homes are built to be accessible, but also that we upgrade and retrofit the existing housing stock. And then just to touch on the community side of things. So obviously, as people have been locked down, they've had to socially distance. And so we've seen some increase in reports of people feeling socially isolated. But on the other hand, communities have come together to support one another in really positive ways. And we've seen a change in that digital access, with older adults who were previously the most likely to have never used the internet now being motivated. So there's a real pull factor wanting to access the internet to connect with friends and family and participate in groups. But we know there's still a huge problem with digital exclusion, whether that's the affordability, access, confidence or skills. And we've done work to look at some of those and have been sharing best practice as to how to close that digital gap. So just a few of the things that we were dealing with pre-COVID, and that we at the Centre for Aging Better still believe are issues that, if anything, are more important than ever for us to address.
Great, thank you so much. And Frida, I want to ask you the same question about, what were some of the factors before and what do we see now more in light of COVID? And as many of our speakers have raised, the COVID-19 crisis has placed newfound emphasis on health and lifespan inequities. So, as you think about this, how do we create change to address these disparities on a population-wide basis?
So I think one of the things that COVID has kind of pushed me into is looking at the system-wide effects. And I want to quote a friend of mine who every time I say the healthcare system, she says, "Why do you keep saying that?" And I say, "Why shouldn't I?" And she said, "Because we ain't healthy, nobody cares, and it sure ain't no system." And I think that I disagree with her in the middle because I think a lot of people care and are working very hard to make changes. But it has amplified the fact that we're not healthy and some groups of people less healthy, if you would, than others. And the system is actually not as responsive to individuals that are different from one another that we need them to be. So I think that this has given us the opportunity to realize that we need new data approaches. One of the challenges during this crisis has been to really understand what's happening to people and to collect data around that so that we could truly understand the issues and then address them with meaningful solutions. So we need new data approaches, data information and health data information tools. And these things would allow us to transform our healthcare system from health promotion and support at the individual level, preventive service, as well as a system redesign. We should also evaluate our current practices, norms, and systems as they exist. I think one of the things that we've realized that contributes to health disparities are differences in each piece of that puzzle. So the practices in communities are different. The norms in communities are different. And the norms in the systems that serve those communities are different. And we need to understand them. And then the third piece would be to use the above, the data and our better understanding of the system to address these at the individual patient, caregiver, and community levels.
Yeah, that's great. So when we started, all of you sort of raised the point that these issues aren't new; they've just been amplified as part of COVID-19. And I think we know that the risk of mortality from COVID-19 is related to chronic conditions such as diabetes, COPD, cardiovascular disease, and these are all conditions that are more prevalent as we age. So, Freddie, you tell us, you're a cardiologist. I mean, I know you still practice, but now you're at Facebook. How did your experience as a cardiologist change the way you think about improving health and health promotion?
Yeah, so thanks for the question. So I'm an interventional cardiologist, which is generally speaking, in terms of where you spend your time, often at the opposite end of what prevention should be. So I spent last week, or just pick a week, any week, and I spend a significant portion of that clinically taking care of patients who are coming in with acute heart attacks, and we do a wonderful job across this country in terms of outcomes of getting folks diagnosed of having acute heart attacks. And where possible, and there's a lot of places that still aren't possible, but for the most part, where possible, to a cath lab, to an operating room, into their vessels, into their coronary arteries, where we can identify the lesion that's causing the problem, and then change the trajectory of that patient going from close to death to back to life in about 90 minutes. So we do this immensely well across the country. But as was commented on earlier, that is not a healthcare system, right? That is you've got a heart attack, you've had 30 years of risks that we could have potentially intervened on earlier, whether that's through community and decreasing isolation, or through statins, or through exercise, weight loss, and so on. all the things we know work in terms of outcomes. But now I'm meeting you on the table when your life is at risk. And even if I do a great job, or all the amazing teams across this country that do a great job in taking care of folks, the odds are your trajectory could have been significantly improved had we intervened decades in advance. And these are generally not things that sneak up on you overnight. And we also know they disproportionately impact people who happen to be on lower ends of the socioeconomic status. And so the question we all need to grapple with is, why are we letting this happen? Why are we not doing more about this? And so as a cardiologist, the question I grapple with is, why am I meeting this patient for the first time on the operating room table when his or her life is about to significantly change? Why could we not do more about this earlier? And why can we not build that system that focuses on prevention? And of course, we already kind of know the answers here, right? There's a system that's built in an incentive system and a stakeholder system that is well established, that promotes me doing a good job in the operating room, and my colleagues would do the same. But we don't spend enough time on the prevention piece. We spend 90% plus of our budget and time focused on treating people who are sick, and that is a dramatic difference from where we should be if we're trying to prevent them from getting ill in the first place. And this, again, accentuated by COVID. Prevention more important than treatment, and vulnerable populations tend to take the brunt of it. So, as a clinician, as somebody who takes care of patients, of being in a family of my wife also being a clinician, the thing we struggle most with is, why are we meeting these folks now? Why can't we do more earlier? And of course, there's a bias, right? I chose to be an interventional cardiologist, so of course I'm at the distal end of meeting patients who are going through this process. But if you look at the public health implications of cardiovascular disease as they've been accentuated by COVID or otherwise, or if you look at it not just in America but throughout the world, we're certainly stepping in the wrong direction here. And my hope is we can do better. We can get in earlier. And of course, things like behavioral change, et cetera, are immensely difficult. The thing I would just push very, very strongly is this concept of a solution that is applicable to everyone all the time doesn't exist. It will never exist. And so the personalized approach of populations, people on the ground, and different communities responding to different things is one that we should sort of embrace fairly quickly in a disaggregated approach to prevention. But I think that's where the focus needs to be, which is, you shouldn't want to meet me in the operating room, right? This is something that my hope is will go away over time if we do a good job. But the reality is the numbers are heading in the wrong direction. They've been heading in that direction pre-COVID. They've been accentuated post-COVID, and we're really not making any systematic change to address this. And as Frida said, systems are important. Being healthy is important, but certainly there's lots of people, including everyone in this panel, that cares a tremendous amount for this.
So that's great. I mean, I'm a policy wonk at heart, so I could wonk out and talk about payment systems and the incentives and why our system is that way, but I'm not going to. I'm going to turn to Richard because, I think the good news is companies like Tivity Health are focusing on prevention and health promotion. They're partnering with a lot of Medicare Advantage plans to really try to help people get healthy or stay healthy, with both, the Silver Sneakers program that you all have, as well as have a nutrition-oriented program too, focused on older adults. Richard, can you tell us a little bit about, because I know, anecdotally, we know a lot of people who just love Silver Sneakers, and as we said, it's also part of social engagement, things that really people look forward to. But you've had to adapt in light of COVID. And can you tell, I know you all recently did a survey of your Silver Sneakers folks. Can you tell us some of the highlights of what people are saying about these opportunities to still exercise and engage with others?
Yeah, and then that you're right. I mean, Silver Sneakers has been loved for a very long time. We're been around over 30 years. And so people understand the brand and they know what it means, and that it means fitness. But first, I do want to reinforce, it's so important that we keep seniors active. Physical activity, good nutrition, good social connection can be just as impactful on your overall health outcomes than even your genetic code. So we didn't have the opportunity to take a break, right? So even though COVID, especially in that March, April timeframe where we had so many of our partnering locations, our YMCAs and our gyms closed, and for appropriate reasons, we had to find a way to do something different. And just one last thing on this, the physical activity of keeping people moving is all the things Freddie was just talking about. Whenever he gets a patient in his practice, and they're maybe overweight, or they've had a acute heart attack, or they've had some other stresses that are causing them to be unhealthy. Physical activity boosts your immunity, reduces stress, and is beneficial in managing all the chronic diseases. Prevents falls, prevents weight gain. These benefits are things that are like immediate, and so we are really passionate about keeping people moving. We did what most companies did, like I highlighted earlier. We pivoted to digital and fast, and everybody told us, hey, this population not quite as digital as everybody else. They're wrong. This group is very digital. They're on Facebook. They're connecting with their kids, their grandkids, et cetera. And so we took the focus of the country to try and slow the spread, slow the curve, whatever the terminology was at the time. And we hosted our first Facebook Live class. Now we have our own proprietary platform, of course. We've got thousands of on-demand workouts available. We're doing 2,500 classes a week. And actually right now we're over 1 million digital live with instructor-led visits since this started. And in the beginning of the year, we had none. So we're pretty jazzed about that. One thing we learned too when we surveyed our folks, you mentioned the survey, about 75% of them are using technology either to do something physical, for medical appointments, or for socializing, or for fitness. And so, if they weren't tech savvy before, they're getting there now. And 50% of them are very comfortable with using Zoom. I talk to many of our members. They know how to customize their backgrounds. They know how to wave their hand. They know all the functionality inside. So it's actually pretty cool. We've heard some fantastic stories too. Our instructors and our fitness locations, they got creative. They're taking safety serious too. So one gym owner we know teaches classes. Her name's Coach Mel. She worked with a member's granddaughter to get a Zoom icon on her iPad home screen. So all she had to do was just click on that and she can get right into Mel's live class. So basically everybody's adapting. And a key takeaway I would say as I finish is that seniors like having this digital option. So when we surveyed them, we said, what are you looking forward to? We talked to them about the vaccine. What are you going to do there? We talked to them about fitness. What are you going to do there? And one of the things they said very, very clearly is digital or virtual is not temporary. It's here to stay. So the future is one of a combination of digital and physical.
That's great. There's so many directions we could go in. A fascinating discussion, but I think I'm going to turn back to you, Frida. Just as a psychiatrist by training, I think we've talked and seen the mental health impacts of COVID on people, and we've talked about that. Certainly, exercise and diet are really important to our health and can help with things like depression, anxiety, other mental health issues. But they also can stop you from wanting to exercise or eat right and do that. What are your thoughts just as a psychiatrist in terms of the mental health component and how that might impact life expectancy and how well people are coping through this crisis?
Well, let's go back to a little bit of the data. First of all, people over the age of 65 or older adults in that category, and younger, older, as well as older, have an increased vulnerability, if you would, to mental illnesses. And that's kind of a baseline. If you add to it the stressors of further isolation, reduced access to food, remember, many older adults are still working and may have been laid off. They may be caregivers either to a significant other or the percent of grandparents that take care of their grandchildren so that their children can work is also very high. So if you add increased isolation, food insecurity, job insecurity, changes in interactions with family, friends, and other forms of isolation, then you have the potential for increases in people who formerly were not affected by mental illness, so those numbers would go up. But in addition to that, you have stress and worry. And in fact, in July, there was a survey that said about 47% of people over the age of 65 were considered worry and stress relative to the effects of COVID on their life to be a significant issue and have an impact on their health. And then again, with all of the factors that I just named, the additional factor of not having access to a primary care physician or a healthcare provider anyway, but now to have decreased access because of COVID is a plus. Add to that increased risk for infection, themselves becoming ill, seriously ill, often hospitalized, and last but not least, the number of losses in older age groups that lead to bereavement make this an enormously critical issue. And so we have to, as a system, if you would, of healthcare, and as individual healthcare providers and caregivers, have to be on the lookout for symptoms of mental illness, depression, exacerbated previous mental illnesses like bipolar disorder or schizophrenia that may become worse under these circumstances. We have to be on the lookout for signs or indications that someone may be suicidal, as suicidal risk could go up under these circumstances. And the onus is not is often on patients to seek their own help, but I think as caregivers and healthcare providers, we have to up our game on actively looking for these symptoms and then intervening where appropriate.
Thank you. I know, Anna, that you all have been looking at environment as a driver of health, and including social isolation, which we can turn to in a minute, but also you've been focused on housing, and you started with that in terms of the quality, affordability, accessibility. What do you think, you've seen more about housing in the wake of COVID, and what's your organization doing to address that issue?
Yes, well, as we've seen more people spending time in the home, on the positive side, I think people are investing more in renovating. The challenge there is that we're really interested in how you can support people to do things in advance. So we were talking there about prevention. We're focused actually more on a younger people in their 50s and 60s who we talk about as sort of midlife, approaching later life. And the problem there is that the products and services that, fittings and fixtures in the homes are just ugly. And so we've been trying to work with designers and retailers to really understand how can we get better designed products, fixtures and fittings that are going to help people to remain independent. But these might be things that you make changes to your home, your bathroom, your kitchen when you do that refurbishment that then going to last you and enable you to remain independent for longer. So that's one area which is really trying to shift the market for home adaptations so that these are things that we all want in our home, simple changes that can help us in the long run. But the other, of course, is how do we make sure that there's just a better aspiration of what a good home is? And things have really come to the fore about light and space, and particularly outdoor space. The things that we've really appreciated, those of us who've been lucky enough to live in homes that have those, and for those that haven't, really the impact on their health and well-being. And that's both physical, so some of the sort of damp, overcrowding, having a really negative impact, in fact, putting people from respiratory disease more at risk of some of COVID and its complications. But also, as Frida was talking about there, mental health. And we've seen, even amongst those people in the 50s and 60s who we've been surveying during COVID, 1 in 3 are saying that their mental health has got worse during this period. So real concern. So we're working we've launched a good home inquiry here in England to really start to look at, well, what constitutes a good home, and what are both the policy actions by government, but also what else is needed in terms of financial services to help people to refurbish, to retrofit their homes so that they can last them a lifetime and support them to have a good quality of life as they age.
That's great. So one question I want to put on the table that's not often talked about before we talk a little bit more about technology is ageism. And I would say the COVID-19 has really laid bare racism. People have really been talking about that much more openly. The Me Too movement really put more awareness about sexism in our culture. But we often say ageism is the one ism people don't talk about that much. And as an aging advocate, I think that we've gone backwards a bit in how we view, and we see a lot of negative stereotypes about older people. And, as I started the conversation, we were looking at a decade of healthy aging, really seeing some people having this gift of 20 more years of life to them, but we see these wide disparities, as we've talked about, in life expectancy based on some social determinants of health, but also how well people, do exercise, eat right, things that they do to reduce their risk. An analysis of tweets mentioning COVID-19 in older adults early in the pandemic found that about 1/4 of all tweets could be considered ageist, either because they included jokes or ridicule aimed at older adults, or because their content downplayed the relevance of COVID-19 and or implied that the life of older adults was less valuable. So I'll open this up to any of you all. We didn't talk about people living in nursing homes, assisted living facilities that we're now going into the 7th month of not being able to see their loved ones often. It's just intense social isolation that there's a balance, I think, between protecting people from getting infected and actually having even perhaps worse health outcomes because of the severe social isolation. That some of that driven, I believe, because of ageism. People say, well, they don't matter, they're old. We want to get everybody back to work and kids back in school, but those old people, they'll just sit there. And that's just not true. The older population is very heterogeneous, as many of you all know. But I just want your thoughts on sort of how much you think ageism has set us back in terms of how we think about getting older, and maybe some strategies we can do to really give some positive reinforcement to folks about we're all still in there. There are ways you can improve your health no matter how old you are. Who wants to jump in?
Well, I'd love to come in if I may, Nora. As you know, I've recently published a book, The Age of Aging Better, a manifesto for our future. And basically the premise there is I set out those really negative stereotypes, both about the age shift, which we see in policy debates, saying a sort of tsunami of older people. We've seen it here with some terrible commentary suggesting that COVID was a cull of older people. So your point that ageism was there, but it has absolutely come to the fore in some of the responses, both in policy and in the media. And again, that everyday ageism that we somehow tolerate, I'm having a senior moment, or that we see on birthday cards saying we're over the hill. These sorts of, they're insidious, but they get into our heads and they change how we think about ourselves and how we think about our future. And if we think negatively about old age and later life, that affects whether we do preventative health things. It depends whether we save for our pension. So these things really matter. And then the intergenerational conflict that, again, I show in the book, the sort of stereotypes of the baby boomers who have it all and taking houses and jobs off the millennials and younger people, just are not based in evidence at all. And again, COVID has played into that intergenerational debate and conflict, almost saying, it's this public health measures to save the old, and all of the economic burden being, taken by younger workers. So one of the things we've been trying to do is really counter that with research and evidence. For example, on older workers, they're as likely to have been made unemployed as younger ages, very similar impacts. But we know that the older workers from past recessions are the least likely to ever get back into work. So the need for support to help older workers get jobs is as critical as supporting younger workers to get those first jobs. So we end up with the wrong policies. So not only is ageism awful for individuals and has a terrible impact on themselves and their self-identity, and age discrimination, stopping people getting jobs, this pervasive negative debate is also meaning that we get the wrong policy solutions. And I think basically that's what I'm arguing in the book, that we need to change how we see this and see it as an opportunity and see much more positively the contribution that older adults make, whether that is through work, through volunteering, through caring for grandchildren, or generally making a positive contribution to society. So I'm interested to know whether that analysis that is quite UK based resonates with you in the US.
So, if I may hop in, I think Freddie said earlier that kind of 100% for everybody solution doesn't really exist. And so I've grown up and been exposed in many cases in the cultures in which I have worked to be in a place where older adults are revered and are seen as kind of necessary daily contributors to our lives, both within our homes and within our communities, are often still teaching and are first responders, as nurses and nurse aides and caregivers. I mean, you could go, taking care of grandchildren, I mentioned before. So there are all of these things that in many cultures, the older you are, the more you're revered, if you would. And my dad lived to be 100. And so I have a great appreciation for the contributions that you can make all the way up to 100 and beyond. And so in those environments, what I've heard is the other end of the spectrum, if you would, which is, oh my goodness, what have we been doing? We don't have the right living environments. We don't have the right responses to protect our older community members. We haven't thought through access. The things, in many cases, older adults don't have access in some communities to Wi-Fi, so they can't go digital, if you would. And so we need, or live in neighborhoods that are not safe to modify their lifestyles in, or to access healthcare in other ways if their usual way of doing so is now interrupted. So my husband always says people don't change when they see the light, they change when they feel the heat. And so COVID has provided a heat to many communities to say we've fallen short on doing the things that we should do to acknowledge, to recognize, to support, and to provide services to, and to value older adults in our community. And we need to do something about that.
Right. I mean, I'm going to go back to technology for a minute, and because when I was doing a panel earlier last week, that you said one of the new social determinants of health may be access to Wi-Fi, and I think we're seeing that in our dependency on technology. And so, Freddie, when we spoke last week, you expressed your frustration that it took a global pandemic for us to increase access to telehealth, even though the technology was already there. But there are a lot of factors that stopped us from expanding that as quickly as we did. Can you say more about how you think technology can better connect us to enhance our health and well-being, and both inside and outside the medical establishment? But then also, how do we ensure people that don't have access to Wi-Fi can reap the benefits of technology?
Yeah, thanks so much for that question. Let me start with the discipline of that and work backwards. I completely agree. I think access to being online is becoming, or I shouldn't even say is becoming, is something that we should all strive to allow or build towards across the entire world. We've spent a lot of time thinking about that At Facebook, we've spent a lot of time thinking about how you get more access to internet to places that generally don't have the infrastructure in place, et cetera. And I think I often go back to thinking through, the concept of telephone lines historically, and how it was so difficult to get, telephone poles and wires to remote parts of the developing world. And then all of a sudden, cell phones made things significantly different, and so you didn't have to build that infrastructure, et cetera. And so there's approaches to doing that. A lot of tech companies have been thinking about that, and it's not necessarily laying cables, but yeah, I think it is becoming a fundamental right of access, just like water and electricity, et cetera, in order to be able to access the things that hopefully will allow us to maintain and grow communities, which I think is fundamental to good health, as well as be engaged in the environmental changes that are occurring as they seek to change the way we do things. Particularly in California, it's pretty important to us today and has been over the last while with all the wildfires that have been occurring. And then finally, just as simply as access to healthcare in telehealth, being driven by, gosh, it still boggles my mind. I've been thinking about this since we last spoke, which is like, it really, in order to get us to this point in telehealth, for investments to occur and for adoption to occur, it really took a pandemic. So my hope is that the next big innovation in healthcare doesn't require that degree of incentive system. And I think this actually falls perfectly in line with Frida's husband's quote about heat rather than light. So that said, I think technology has a very important role to play in making us be human more, as opposed to technical more. And so the way technology plays a role in my life is that I can connect to my dad, and my dad can read bedtime stories to my kids before they go to sleep, even though he's prohibited from coming here because of the COVID restrictions on travel and so forth. And to make that seamless, to make access to healthcare seamless and designed around each community the way they feel it should be for them, I think that's where technology plays a role. Again, I've said this before, and it's counterintuitive for someone who works in technology, but I don't think tech matters. I think people matter, and if we can use tech to make those things better, then we should. So an example of aging better at home is the risk stratification that often needs to occur over time. And it's fairly nuanced and is difficult to ascertain unless you're a primary care physician who's really well in tune in the old school way of doing things and seeing a family grow over decades, which certainly doesn't happen with urgent care and telehealth visits or switching, et cetera. So the question is, can we use technology today to improve our ability to connect as humans, as well as think towards the healthcare of tomorrow, which is fundamentally improved risk stratification and care virtualization in a way that makes us all better? And I think the answer to that is absolutely. It comes with a bunch of caveats, and we have to figure out the rules and regulations to get there and generate the evidence that that kind of thing matters. But I think aging in place, and Anna Dixon had mentioned this earlier, is setting up the home for it to be a place where it actually provides more safety rather than less than a hospital, I think is an important sort of place to start thinking about it. So yes, I believe technology is very important, but I don't think technology is important. I think allowing humans to be themselves more and engage in the ways that make us more human is ultimately what we're going after. It's just, my hope is technology can make that less friction, make it frictionless or less with less friction overall. And at the same time, provide tools that we don't currently exist that allow us to be apart but still be together. And risk stratification and care virtualization sort of get us there. I'll stop there.
That's great. Anyone else want to jump in on this technology issue? See there.
One thing
I just wanted to add.
Go ahead, Frida.
I just wanted to add the idea that in addition to care, data collection, data analysis, and really understanding what people need or want for prevention, for diagnosis, for treatment, and for wellness overall is really a keen opportunity that we haven't tapped into fully using technology. So observables, wearables, interacting with patients and using that as a platform to understand more about how they're living their lives, what might be barriers to them having the most healthy years possible, is still wide open for us, and we have an opportunity to do the entire spectrum.
Richard?
Yeah, I was just going to comment on, and I agree with that point on data. I think it's a pretty strong one. I think, we've got to kind of compartmentalize the problem a little bit, meaning, our rural part of our country, a fourth of them don't have, that's a fourth of our country live in rural. They don't have access to this type of capability, whether it be broadband itself or even, high capacity internet. So I think that's one thing is kind of looking at the disparate urban versus suburban versus rural. That's one kind of large issue. And as we know, a lot of our health disparities sit out in rural parts of the country as well. And one is around education. They're adapting. Seniors are adapting to technology pretty well. And 50% of them, that when we survey them, they go, they're pretty comfortable. But the other, like live streaming and video and things like that, but half of them aren't yet. And so thinking about like what Facebook does or what like Apple could do or others around, educating seniors on how to be able to engage in the technology. Just one on the health disparity point. I think that gets really local. So there's a lot of cultural things that happen in communities as to why people won't engage in certain capabilities that are available to them. And community-based organizations are playing a huge role here. They can help with the gaps, they can help with the solutions, they can help connect to providers, and technology is a big part of that. The last thing I'll say is I agree you got to meet people kind of where they are. And we were talking about ageism a bit, but my mother and my aunts and uncles, they all have Apple Watches. They don't have an old person's watch. They have an Apple Watch. Why? Because it's cool and it does everything that they want to. And so thinking about how we use technology, I fitness share with my mother, and it's a hidden way for me to know that she's up and about every morning because I can look and see how much activity she's had. And so there's small ways that technology are helping people be their best selves, also as it relates to healthcare.
Yeah, I think that's a great point, Richard. And, I also have a, Fitbit group that you sort of know if somebody's not doing well. It's that sort of mental health check. They're not walking or something. Hey, what's going on with you?
Yeah.
Like, haven't really taken any steps. It's, it can be a real way to bring people together. And I also, when you were talking about the not an old people watch, again, it's, I think MIT Age Lab did some really interesting work comparing services that people now adopt that millennials do that used to be considered, you didn't want to have people come into your house to bring your groceries or be a handyman. And the millennials just changed all that because, they just have an app for everything. And in some ways, I think it's really helped older people also be able to, have groceries delivered, things brought to them at home that make them stay independent for as long as possible. We're starting to run out of time, but we do have a question from the audience I wanted to make sure that we addressed. I think when we were talking a lot about the social determinants of health and things that impact your health, one of our audience members said, but, where does personal responsibility come into this? And so I think, as we've said, there are things that are certainly related to some determinants of health, but some things that we can do to be healthier. And where do you all think what's the role of personal responsibility in sort of increasing your health span?
It's a nice controversial question. Should I jump in again, or Freddie, were you about to? So we see that the differentials in how healthy people are as they age as being something that is an accumulation of disadvantage over the life course. And so when you're talking to somebody, who's 55, who's already got some long-term health issue that's affecting their ability to work or fully participate in society, it's very hard to talk to them about personal responsibility if actually the job that they've been doing has had a really negative impact on their health because of its physicality or its stress. If the place that they've been able to afford to live, their home, has negatively impacted. If, as we were talking about there, people didn't feel safe to get out and about. So we tend to be interested in the structural things that we can change, which can help make it easier for people to avoid the harmful things, smoking and excess alcohol, but also to do the right things, so more physical activity and weight loss and so on. So I think it's really important that we do focus on those structural determinants, because where we've seen in the past, the evidence is if you just try and educate people about what's healthy, it actually worsens inequalities, because those people who can do, and those people who face significant challenges and barriers don't. So that's why Aging Better is more focused primarily on some of these structural determinants. But it's not to say that, of course, we do all need to then, make the most of the opportunities if we create them. But we're much more likely to change our behavior if we make it easy to walk, if we make it easy to eat healthy food, and that's what we're trying to address.
That's great. So we're almost out of time.
Can I jump on that for a second as well?
Oh yeah, go ahead. We're going to wrap it up though.
I will, but so this is a great controversial question, as Anna mentioned. I think we should look at the data, and I would argue that personal responsibility as a variable, as a characteristic, doesn't change between where you live or what your income is or your education or race. We're all very similar in that sense, and I think the question remains if personal responsibility, given the data, isn't the reason why people are doing poorly in certain parts of the country and better in others, then what is? And so if that's the case, we should come together, try to figure out what those things are and try to fix them. But my suspicion is, generally speaking, regardless of what your level of personal responsibility, it tends to fall in a bell curve, and we're all much more alike than different here in being able to actuate it. And I will say, I have found, regardless of and I said this actually at the last session we had together last year, which is the thing that I found that actually works most for getting people, including myself and my father. So I'm well part of this ring of personal responsibility, trying to get better at it. The thing I found that gets people actually motivated to exercise more and move more, etc., tends to be getting a dog. And so I think that's an important piece of community and personal connection, and having to go outside a few times a day by design. That gives us some hints towards what tends to work for folks. But I'd say personal responsibility is something we all struggle with, and for the most part, there's really not any groups that are better at it than others. And I would argue it is not the reason why we have health outcomes differences across the country.
Great. Okay, so rapid fire answer to the last questions, lightning round. I always like to finish on a positive note. So what do you think is the silver lining from the pandemic? What makes you feel positive right now about healthy aging? Let's go, Freddie, so let's go to you first, Richard.
Yeah, I'm optimistic because in our surveys, what we hear from most of our beneficiaries is that they want to get back to what they had before and maybe even a little bit better. So I think digital's helped with that. I think they're embracing the world differently than they were before. And all of the trends that were better for the population are just being accelerated. This crisis has been terrible. And in another way, it's been a catalyst for change. So I see a positive on the outside. Once we get into whatever the kind of new world is going to look like, I think a lot of folks are going to have a much different mindset around how they're going to live their lives.
Great. Anna.
Yeah, so I would add to that the changes in the workplace, we know that older workers have wanted greater flexibility. Well, that's been accelerated. And we just need to make sure that and recognition of people's health conditions and caring responsibilities from employers, that continues and people are really supported to stay in work and to manage that flexibility that they need as they work into older ages.
Great, thank you. Frida.
I'm very optimistic that people have begun to do the thinking as well as the actions that are responsive, not just to what is happening now with COVID, but are thinking, how can this and should this change us moving forward? So we're looking not where we fell, but where we stumbled, and are beginning to think about how to remove those barriers. And I think that'll give us some sustainable transformational change that is sorely needed.
That's great, Freddie. And other than get a dog, what other things make you hopeful?
Telehealth. It's
Yeah, that's great. Really changing. Well, thank you all. You wrapped up. It was a great conversation. Looking forward to this, and we will follow up with you all. Really appreciate you being here. It was really stimulating. Have a great day, everyone. Thanks for listening.
Thanks very much.
Thank you.